I can have an example of a patient, not too old, 71-year-old, that she came referred to me basically because I'm part of one of the trials on the use of transcatheter aortic valve implantation in patients with moderate aortic stenosis and heart failure with a reduced ejection fraction below 50%. The rationale behind that trial is that patients with moderate aortic stenosis and impaired left ventricular systolic function, they may have more symptoms and they may have a worse prognosis because the ventricle is not in a good condition and has also an obstruction that is the moderate aortic stenosis. According to the current guidelines, if the patient doesn't need revascularization, coronary revascularization, that patient needs to be treated medically and with guideline-based medical therapy for heart failure. But we know from some retrospective data that these patients do not do well. So since we have now transcatheter aortic valve implantation and we know that we can perform the procedure under local anesthesia and is safe, would be reasonable for these patients to try to solve the aortic valve problem and see whether the patient improves in terms of outcome, in terms of quality of life and reduction of symptoms, and also in terms of left ventricular systolic function. So to find those patients sometimes is difficult, but we can find them. And this patient came to me referred for the possibility to participate in these studies. She's 71-year-old and she has a history of diabetes, atrial fibrillation with various radiofrequency catheter ablation procedures and always recurrent atrial fibrillation that made her very symptomatic. A couple of years ago, she also had a percutaneous coronary intervention that was because coronary artery disease was diagnosed during the performance of a CT coronary angiography to plan a radiofrequency catheter ablation because of atrial fibrillation. They were detected there 2 lesions and they were treated with a stent. And in one of the echocardiograms, the patient has reduced left ventricular systolic function, atrial fibrillation, and moderate aortic stenosis. Now, this patient, because she is not well controlled with medication and despite the various ablation procedures, she has recurrence of atrial fibrillation, was offered the possibility to do his bundle ablation and implantation of cardiac resynchronization therapy. And despite that, the patient comes to the emergency department with decompensation, with heart failure. So when she comes to me, I explain the rationale of the study. I check the echocardiogram and indeed it's a moderate aortic stenosis, but a little bit doubtful because these patients, they are quite challenging to diagnose the severity of the aortic valve. If we measure ourselves, the aortic valve was 1.1 area, square centimeters for the area, but the gradients were low. And that can be because of the reduced left ventricular systolic function. When we send the images to the core lab said that was severe aortic stenosis. So there is, where do you do the next step? What do you do in order to discern whether it's moderate aortic stenosis or severe aortic stenosis? So the core lab recommended the vitamin stress echo that we did. I was much more in pro of performing a computed tomography because if we are thinking that this patient will benefit from transcatheter aortic valve implantation, we will need the CT anyway. And the CT, based on calcium score, will give us a surrogate of how severe the aortic valve stenosis is by measuring the calcium of the aortic valve. When we did the vitamin stress echo, it looked severe because the area was around 0.9 and the gradient increased. And when we look at the CT, the aortic valve calcification is very much high, it's above 2,000. That will indicate for a woman that is severe aortic stenosis. But we were a lot of, there was a lot of controversy because actually the calcification of the aortic valve was much more related to the aortic wall and not the aortic valve itself. So that posed a lot of discussions, and eventually the patient was considered to have severe aortic stenosis based on the dobutamine stress echo. The patient is waiting now for a transcatheter aortic valve implantation outside the trial because it's not moderate aortic stenosis. But I think that that is an example where you have the help of various imaging modalities, where it could have been maybe better to see how the disease has progressed and how to see the different echocardiograms during follow-up and also the CT to see how the calcification of the aortic valve has evolved, and maybe put the label earlier that this patient, the main problem is the aortic stenosis, and until we don't solve that, the patient may not improve. So this was an example that is quite controversial, that is not so easy and straightforward as we think valvular heart disease is. And you have various disciplines involved. In this case, for example, the electrophysiologist for the atrial fibrillation, the heart failure specialist for the treatment of the heart failure, and the imager and the specialist on valvular heart disease, and the interventionalist to decide which is the best treatment for this patient.